Hello and good afternoon. My name is Indranil Chakravorty. I'm a consultant at St. George's University Hospital in London, and I'm delighted to be here on behalf of the Bapio Institute for Health Research to talk about our project, Bridging the Gap, which is about tackling differential attainment and finding consensus solutions. So let's touch first on what is differential attainment. It's the differential achievement between different groups of people, not based on their academic ability or their prowess or their effort, but actually on the bias that exists within systems and that leads to a different experience and opportunities. Essentially, it is a reflection of an unfair society, and the causes of inequalities are often deep rooted and go back several years into the past. This is an excellent cartoon, which I'm sure many of you would have seen before. And it shows essentially that all of us individually are very different. We have different history, different training, different upbringing, and we bring to the table multiple different skills. And if the bar is set equally or the same for everybody, we are inevitably going to lead to further discrimination. And that is one of the fundamental tenets of this particular project. Why is it important to tackle equality? Because essentially it is a fundamental right for all humans. It's enshrined, by United Nations. It's enshrined in the constitution of several countries, including the Equality Act, most recently updated in 2010. So we all have a public sector duty to ensure that equality is available to our patients and to our workforce. The history of differential attainment goes back several hundreds of thousands of years. But as far as the UK medical profession is concerned, it is identified and reported even before the inception of the NHS. And we know that it is manifest in differential opportunities available to professionals from different parts of the world who've immigrated to United Kingdom. And over the years, it has affected people from Irish immigrants to South Asians to people from Caribbean islands to East Europeans. The list is endless. The important thing to remember here is that differential attainment is not unique to our health system or to the United Kingdom. It is present in every country, in every health system, or in every walk of life and profession. And equally, it is also not only about people from, who've moved from other countries or other nations. It is also about protected characteristics and individual characteristics, and eventually leading to economic and social deprivation. A very important watershed year was in 2014, which led to the culmination of the British Association for Physicians of Indian Origin case against the Royal College of General Practitioners. And the contention was that there was discrimination in how the clinical skills assessment examination was dealing with different people. Ultimately, the legal case was lost because there was not enough evidence to say that there was deliberate discrimination. However, there was a moral victory and a requirement placed on the RCGP to tackle the phenomenon. The GMC took this on, along with lots of focus groups and workshops. And in 2015, looking at the evidence, found that there was enough quantitative data to suggest that there was a differential attainment in high stakes exams, but there was no clear evidence of bias in either the nature or the structure of the exams themselves. There was not much evidence from other areas, but since then, there has been much more work done in this. Essentially, we understand that for different cohorts of people within the medical workforce, We are all in the same storm, but not in the same boat. And this was highlighted by Damien Barr, who's a columnist and author in 2020 in relation to the inequalities that we saw in COVID-19 pandemic. So going back to the causes, the essential causes are systemic. This is about an existence of conscious and unconscious bias, structural discrimination that exists and that separates people on the basis of race, ethnicity, culture, gender, sexual preference. It leads to, over years, multiple deprivation in education, social, economic areas. And there is a particular cohort of people who are the international medical graduates who are not necessarily coming from educationally or socially deprived backgrounds, but because of the fact of being, from overseas, there is a structural discrimination against this particular group, and that is recognized well. There are also multiple factors within the organizations, networks, allyships, diversity and inclusion, or lack of it, lack of identity, linguistic ability, and lots of other factors which at an individual or an organization level may make a difference. There are some controversies, as you would have understood recently from the literature on racial disparity, about there is a lack of consistency in how ethnicity is considered, is described, and there are different schools of thought on why people should not be aggregated into one artificial entity, for instance, a Black and Asian minority ethnic, because they are so varied and so different. So one of the schools of thought that the group we've been working with have thought about is about disaggregation of this data and trying to look at where the experience is common versus where the experience is very different. And it is essential to establish this in order to move forward in our research. So what is the impact of DA? At an individual level, it can wreck lives of people. They feel demotivated, disenchanted with the whole system, and leads to loss of staff from the workforce, which is at a huge cost to the taxpayer. At organization level, it creates to extension of training, difficulty, sometimes patient safety incidents, and sometimes lots of legal and ethical challenges. At a national level, it is a travesty of a country where the medical workforce is so challenged that we are not able to provide an equal footing to all our workforce. So the Bridging the Gap project was instituted back in the middle of 2020, right when the country was just coming out of the throes of the first surge of COVID. And it's a collaborative project with all major stakeholders, including the General Medical Council, higher education institutions, Health Education England, and also the NHS Race and Health Observatory, which was created during the pandemic, and a whole host of grassroots professionals, professional groups, and experts. This project has looked at the comprehensive picture of differential attainment. So it's gone from entry into medical school to career progression, to assessments, both at formative and summative level, to research and academia, and leadership roles, including fitness to practice, complaints, professionalism, the whole spectrum. The process has been that there are 6 particular groups of researchers who have undertaken a thematic synthesis of the literature available, including literature reports and grey literature. And then it has led to reports that have all been published, which have then been discussed in focus groups and priority setting partnerships over multiple meetings. And then it led to questions that were considered for discussion between experts, grassroots, and stakeholders in consensus developing workshops. The output that we are currently working on, and is due to be presented in August, September of this year, will include a series of recommendations. They will include also actions for different organizations, policy enablers, and areas for further research. And it is promising to be a very comprehensive document. These are the dates of the workshop, starting in November and finishing most recently in the end of March. So what are the recommendations? I must qualify this by saying that this is at present just draft, and we are working on it. So this is just a quick look at where we might be going with this. Firstly, it's about acknowledging that differential attainment and systemic inequalities exist. Unless we agree that there is a problem, then we cannot move forward. And this has to be done at the highest level of the country and of all organizations. And we also need to see a significant, serious commitment and intention to achieve equality and justice for all organizations. And fortunately, we have consensus on this. Secondly, in order to know where we stand and where we need to reach, we need data. And the data has to be comprehensive, it has to be holistic, it has to include all protected characteristics, it has to be transparent, and it must mean something, not only to grassroots professionals, but also to organizations. We are talking about setting up a framework which includes intersectionality. We're also talking about a roadmap where there'll be national benchmarking to see how institutions can compare themselves against their peers. The next bit is about accountability. And there is significant consensus that organizations at the highest level, so chief executives, chairperson, have all got to be the accountable person for achieving equality. And there must be oversight bodies, so national bodies like the regulator, Academy of Medical Royal Colleges, Health Education England at the national level needs to be the bodies that monitor progress. And ultimately, it has to sit with the people and therefore the parliamentary ombudsman. The next important overall recommendation is about ensuring that equality, diversity, inclusion principles and our public sector duty to honor them are done at every level of every organization. There are now initiatives about EDI champions, EDI networks, which are being set up and empowered in every organization, and they need to be taking charge of this agenda. We also need to know that EDI networks are being effective in how they achieve their targets, and they should have really achievable targets. The fifth recommendation is about review of the equality impact of every process, going from recruitment to leadership, to research, to grant funding, to career progression, the entire spectrum. We need to know that the processes are robust. Processes do not discriminate against people because of their background. And where they are not robust, we need to rethink, reform, and completely start from scratch again. The sixth recommendation is about removing the difference between a career doctor versus non-career doctor, a trainee versus a non-trainee, appointments done at local level, national level, and a complete mess of the job descriptions and support that is available for a huge proportion of people. There has to be an agreed national job description. There has to be an agreed national recruitment process and support that is available for each and every doctor in the country. The seventh recommendation is about acknowledging the contribution of international medical graduates, not because they are different, but because they come with a huge ingestion into the economy. Because the huge cost of training a doctor is being borne by other countries and other nations. So it's a huge contribution, again, to the UK economy that we are not having to train them. And then we also need to recognize the diversity of medical training that they bring into the country, which is a huge asset. And finally, the cultural insights that they bring, which will make it so much easier for organizations if they were empowered to recognize this in order to serve our diverse UK population so much better. The eighth recommendation is about having personalized training passport for all. So we have to commit adequate resources, which is not only money in study leave resources, but also time for training and trainers within their job plans to be able to provide high quality training for all. We also need to be able to support flexibility and alternative training pathways and alternative job plans for people who wish to do so. And then the supervision and resource for returning to training for people who've taken time out to leadership, research, and other things needs to be available not only to Health Education England NTN holders, but to every doctor in the country. Finally, it is all about looking after our staff. The NHS people plan. We need to acknowledge the stress and demotivation that DA causes. We need to provide pastoral support and mentorship for everyone, and also provide enough support for individual health, looking after families, parental or caring responsibilities, and particularly something that is relevant for international medical graduates is the support available for them to look after their own families and sometimes aging relatives in their home countries when they are devoting their time and expertise in the UK. I'll leave you with a very commonly used slide, which has really touched the hearts of most of the people that have been working on this particular project. And these 4 cartoons show how tackling inequality through supporting individuals is not effective, how giving more support to individuals who are underrepresented is also not adequate. But unless the system is changed, we will never achieve equality or justice. So I leave you with that thought, and we will be looking forward to questions and your further